Hi everyone, it's me, Professor Bunker, here with your next NCLEX review session. We are going to go through Basic Care and Comfort Boot Camp today. Okay, so flashing back a little bit to fundamentals. I'm going to do my best to wrap the entire fundamentals course pretty much in a less than 1 hour presentation. So bear with me. We're going to roll through this pretty quickly, but let's go. Let's jump right in. Hopefully by now you have gone through the NCLEX test plan. If you haven't, search it online. You can download it. It's a free PDF. Gives you descriptions of each of the NCLEX client need categories and gives you a pretty good example of sample topics as well. So basic care and comfort is one of the categories, one of the client need categories. One of the smallest client need categories, though, I will say 6 to 12% on average of a typical NCLEX exam. That's kind of small. However, we know how the NCLEX runs. It is adaptive. So if it recognizes that this is a weak point for you, it's going to ask you more questions based on these topics. So let's just shine it up a little bit, make sure you feel extra confident in it, go from there. All right, so their definition of basic care and comfort is providing comfort and assistance in the performance of activities of daily living. Okay, so going all the way back to ADLs, that's your bathing, toileting, getting dressed, moving around, right? Basic needs, okay? We're talking about physical comfort, functional ability, and all-around well-being. So it's a good summary of the topics that we are going to talk about today. You also have to incorporate skills like prioritization, looking at safety components. Therapeutic communication is always a part of really any topic, but especially when we're talking about basic needs. The thing that I love the most about this category is that this is what distinguishes us from any other healthcare provider. Okay. If a patient is constipated, any clinician, anyone that can prescribe is going to say, all right, let's give them a stool softener, let's give them a laxative, do an enema, whatever it may be. We, being the eyes and the ears of the whole care team, basically being the one that's at the bedside with the patients, we are the ones that would step in and say, but we haven't educated the patient on increasing their fiber intake yet. Let's have a few fiber-rich meals and see if we can get a bowel movement that way. That's basic. That is least invasive. Good term that we're going to bring up again in a minute. But yeah, let's increase fluid intake. Let's get them up moving around more. You know, there are a lot of other interventions that we can do for something like that, constipation, rather than jumping to medications first. Are medications guaranteed to work? Yeah, absolutely. But again, you also need that order to be able to do that. So say you can't get a hold of the doctor, no matter what the situation is. There is something that you can do as the nurse, something. So start there. That's your role. That's us as nurses. Okay. So long list of topics that the NCLEX test plan gives you, but here are the big ones that I want to start with, go through with you today. We're gonna again brush up on prioritization and then we'll jump right into hygiene, talk a little bit about nutrition, not your whole nutrition course that you took, but some topics related to fundamentals, basic needs, nutrition, and of course related to that, elimination. We'll talk about ambulation and immobility, the effects of immobility, skin integrity, wounds. I love wounds. So weird, but I love them. Comfort, rest, and sleep. Very underestimated. We think, oh, we know what these interventions are, but do you really? We'll talk about them. Complementary therapies, that's like alternative medicine. We'll talk about some other options that patients may choose to take. And of course, therapeutic communication, those concepts that we're going to include in basic everyday interactions. And we will end, I shouldn't have put this at the end. That made it end of life care is our last topic. Okay. Wrap it all up, I guess. The end of someone's life, the end of this presentation. Dun dun dun. Make it sound morbid. All right, let's jump right into prioritization. So the way I've organized this slideshow, we've got a nice title page. The next slide after this is going to be a practice question. After that, I've got a slide with some bullet point content information that we'll talk through. But I really want you to be an active participant in this presentation. So when I flip to these practice question slides, I'll read them. I want you to pause this video. I want you to pause. I want you to think about it. Answer it for yourself. Okay, I don't want you to go through this whole presentation just listening to me talk the whole time. I wouldn't want to listen to that either. So again, play along with me. Okay, so here's your first practice question based on using prioritization techniques. Let that help you if it may. A client with bilateral lower lobe pneumonia reports increasing shortness of breath and mild anxiety. The patient is currently receiving 2 liters per minute of oxygen via nasal cannula and has an oxygen saturation of 91%. Which action should the nurse take first? A is increase the oxygen flow rate to 4 liters per minute. B, assist the patient into a high Fowler's position. C, notify the healthcare provider. Or D, prepare to administer nebulized bronchodilator. Okay, pause at this point. I'll say the answer in 3, 2, 1. Hopefully you got the answer B. B. Why B? In clinical, maybe even in practicum, does your nurse just walk in the room and bump it up to 4? Like, that's probably what they need. We're just going to bump it up. Possibly. Okay. This is a patient with pneumonia, did not say that they were not coherent. So if it was like a comatose patient, we might not have the same reaction out of them. Same with if you're in like the NICU and the baby's on oxygen. Can't really tell them to do things. Sitting them up may not be effective. But in this case, it is. What does sitting the patient up in high Fowlers do? It helps the lungs expand easier, right? Increased lung expansion helps to make breathing a little bit easier for them. I also note in the stem of the question, mild anxiety. When you're anxious, are you putting all your effort into doing what you're doing, breathing effectively? Not really. So even if it's assisting them into this high Fowler's position, oh, and I didn't realize that I left patient in there. It should say client. One of my old questions. My bad. It'll say client. But when you are getting them out of that position, you're also helping them to calm down. Okay, whatever that may be. Take a big deep breath with me. I'm going to do it with you. Whatever that may be. Think in real life application, right? Um, all of these answer choices are interventions, right? They're all things that we can do. All of them probably be effective outside of which one? See, you're not really doing anything when you're letting the healthcare provider know. They're going to say, okay, they have pneumonia, they have oxygen on, bump it up, do something else with them. Have they used the incentive spirometer today? Et cetera. They're just going to ask you questions. They're not necessarily going to do anything else depending on the patient's situation. Okay, but all in all, what is the strategy that we're using in this type of question? Least invasive. Okay, again, a term you're going to hear me say a lot, but we need to start with the least invasive option. Most of the time, that's going to solve our problems. So if we can avoid giving an extra bronchodilator, maybe later on in the day when they need to ambulate, no, not later on in the day, but within the window between times that you can administer it, they need to ambulate. Let's save it until right before they're going to ambulate. That kind of idea. Okay, we got to think through the whole picture. But given just this snapshot, we're going to try the least invasive options first. Let's sit them up. Let's have them cough and deep breathe. Try all of those things before you jump to either increasing the oxygen, giving a nebulizer treatment. Lastly, you'd call the healthcare provider and give them an update, especially if those interventions were not helpful. Okay. So again, just an overview of least invasive versus most invasive as a prioritization framework. All in all, the NCLEX is looking for you to choose interventions that are effective, safe and least invasive. This is just kind of like a well-known statement about the NCLEX. You've got to try those first before doing anything else. And again, caveat, if you've got this super, super acute patient, they've got something crazy going on, they need some intensive care and help, maybe not put a Band-Aid on it. Let's go do CPR, if we need to do CPR. So this doesn't work for every single question. But again, if we're talking about ADLs, if we're talking about a simple complaint or simple issue, this will work. Okay. So let's define least invasive, something that does not penetrate the skin. It's very minimal risk, no medications, no treatments, typically no prescriptions. It's nurse driven. Okay. So some examples there for you. Okay, and think back to the last question as well. We used repositioning for that. Most invasive uses medications, devices, procedures. Okay, think things that are ordered by a provider. Okay, IV lines, medications, feeds. You got the picture. On the NCLEX, in this category especially, they're looking for you to assess first. Okay, depending on what the situation is, you've either done your assessment or you need to assess something before you move further. All right, hold that thought because we'll talk about that in a second. Then when you need to complete an action, you're going to start with the least invasive, non-pharmacological intervention and move on from there. Again, not to keep repeating myself, but this is really important. These are big, big strategies to use. Here's an example. Your patient is nauseous. What are we going to do first? Are we going to leave the patient's bedside, run to the bedroom, grab on Danzatron, your Zofran, come back, prepare it, put it in the IV? Could we have done like 5 other interventions in the meantime? Probably, right? So even if, well, typically, especially with something like nausea, you want to eliminate any triggers, eliminate what might be causing that. Say they ordered fish for lunch and they've got their lunch tray sitting right next to them. And all of a sudden, once they opened it up, they were like, oh no, that's not doing it for me. I'm nauseous. I'm gonna vomit right now. First things first, get the tray out of the room. Move the tray out of the room. Okay. Even if it's just the plate of fish, whatever it may be, get it out of the room. Maybe repositioning will help. Depends on what position they're in. Could be that they're ambulating. They start feeling nauseous. Let's help them to sit down. Okay. Least invasive. Little hacks that we use in the hospital, like using an alcohol wipe to sniff. There's all kinds of things that you can do before, again, leaving the patient's bedside to run and grab the medication. Will it help? Absolutely, if the nausea persists. But let's start there. Okay. All right. Obviously, goal is to minimize harm. We want to avoid any unnecessary procedure. It also encourages our own autonomy to be able to do these things, like I said before, that are in our role. This is our role. We can do this. So the question to ask yourself when you're debating on these answer choices, what can I do that is safe and easy before something that is invasive? Is it appropriate? Let's do it. Okay. All right. Another prioritization technique to talk through. You're like, prioritization technique, the nursing process. I mentioned this in saying that they're going to look for you to complete assessments before you complete an intervention. It's listed right out there for you. You got to gather all your data first, then you put it all together. What you might have learned as diagnosis, we now call analysis, AA-PI. So we're going to say, okay, I think this is what's happening. Here's the plan. This is what we're going to do. Implementation is when we complete those actions. So all in all, if we're following the nursing process, which we should in everything that we do with our patients, that's our process, again, our own autonomy, then can we physically complete an intervention without completing the assessment first? We wouldn't be able to go on with this process. So yeah, practice question directly related to this. A nurse enters the room of a client who had abdominal surgery 12 hours ago. The client states, I don't feel right. Something just feels off. Which action should the nurse take first? A, administer the prescribed PRN pain medication. B, notify the healthcare provider of the client's statement. C, perform a focused abdominal assessment. Or D, analyze the client's most recent laboratory results. Again, answer for yourself. I'll say the answer in 3, 2, 1. Your answer is C. Okay. Again, we just talked through this. Do we know that something bad is happening, right? They just had surgery. Could be the start of a paralytic ileus. So if I B, notify the healthcare provider, again, what kinds of questions are they going to ask me? Do they have bowel sounds in all 4 quadrants? What is this? Is generalized? Do they have pain in a certain quadrant? Have they ambulated since surgery? All kinds of questions that they're going to ask you, right? Start with assessment. Again, if that's an option, do your assessment, okay? Did you think about D at all? Question. Because, could it be seen as a form of assessment? Maybe it's going to give you data, but also most recent laboratory results, they could be pre-op labs from, more than 12 hours ago. So not necessarily going to be helpful. We want to look at the patient first too. Okay, kind of like if the O2 sats drop and we're just looking at the monitor, but we're not looking to see that the pulse ox probe fell off their finger, right? Start with the patient. Okay. And again, they didn't necessarily say that they had pain. They just feel off. So not really indicated anyways. All right. But hopefully that's all in all a good refresher of prioritization. Let's jump into our first real kind of fundamentals topic of hygiene. Here's another practice question for you right off the bat. A nurse is caring for a client with a spinal cord injury who requires assistance with personal hygiene. Which action should the nurse take first? A, prepare the shower so the client can independently complete hygiene. B, perform a complete bed bath for the client. C, provide adaptive devices to support the client's participation in hygiene care. Or D, offer the client a bar of soap to use during hygiene. What do you think? I will say the answer in 3, 2, 1. Answer C. What did you think about C? You have to use a little bit of your knowledge of spinal cord injury. So we're going to assume that this patient has impaired mobility to some extent. Are we ever going to assume A? Not really with a diagnosis like that. They can't really independently do much. We're at least going to want to be there to assist. And the same idea really goes with D. Did you think about it in that way? Kind of bar of soap to use? The bar of soap is actually what is the issue because having grip and strength with this kind of diagnosis, not super common, and especially if it slips right out of their hands, falls down, would they even be able to get it? They pick it up. It assumes independence for sure. So if I were you, I would have been between B and C, but what is B doing? It's completely taking everything away from the patient, just doing it all for them. Another important aspect of basic care and comfort is independence, self-care. Okay. So we need to give them the opportunity to be able to try. Now, say they can only help for 60 seconds, even less. We're going to give them the opportunity to be able to do that. Otherwise, it's like that old saying, if you don't use it, you lose it. It's even more amplified with our elderly patients, right? All of a sudden, they can't do any of their own care anymore. So we need to be able to support them. We're going to give them devices. Think about like a long-handled brush. Even if they've got one arm of movement, they can wash their whole back, their front, maybe even down their legs. Give them the opportunity to do that, okay? So some topics to kind of think through. Bathing, kind of like we just talked through. Least invasive options, giving them the opportunity to start. Partial bed baths would be preferred if they're not independent. but move along in that order. Start independent, partial if needed, complete if absolutely necessary. Okay. Oral care is a common one that gets asked about, surprisingly. Think about what you learned about completing oral care. Again, we'd rather them independently do it if they can. Gather all of the supplies, bring them right to their bedside, a little spit basin on hand, cup of water, everything that would be needed, and instruct them on how to do it all. Unconscious is obviously a little bit different. We're going to want to roll them to their side, right? Could you imagine, especially if they're supine, brushing their teeth, they're going to be gagging on it. A little bit of a different story if they are intubated. You're using those swabs, oral swabs. That can be different. Have suction on hand too, though, because you don't want to have any issues with their spit or anything coming from the toothbrush or swab. Okay. Now, what do you remember about dentures? Care of dentures. This is one that they like to ask about because it's commonly an issue that they get lost and they're expensive. They're personalized, a special fit for each individual person's mouth. So be very gentle with them. When you take them out of somebody's mouth, you want to use gauze. Hold the denture with gauze, pull down gently. There should be a form of a glue in there of some sort to hold them in place, typically. So be gentle. Take them to the sink. You can use a soft bristled brush to brush them off. And there's typically a special denture cleaner that most facilities have and special denture containers to put them in with a lid. You always label that lid. Everything is individualized for that patient. Okay. How about something that I commonly see come up is they'll say just put them in the sink, wrap them in a washcloth and put them in the sink or something like that. That's not safe. That could be hit by anything. Make sure that they are in a container, keep them safe. They want dentures in when they're going to be eating, or again, if we're just thinking about their comfort and their dignity, ask at any time if they need help replacing their dentures. Okay. And thinking of more so bathing, perineal care, think cleanest to dirtiest. It's same concept with eye care, right? Cleanest to dirtiest. Same with especially your patients that have vulvas, vaginas. You start in the very front and move posterior, ending with the rectum, right? If you are doing that, perineal care, especially in that order, you're using a different spot of the washcloth every time you go back to the front. That's a great way to get yourself is wiping back and then going back to the front. Oh, different spot of the washcloth and then wipe again. Okay. Nail, hair, and skincare depends on the patient. It's going to be individualized. Again, aim to assist, offer them options, but ultimately to their extent, to their desire. Think about special considerations for patients who are immobile or high-risk patients. So in our example, we had a patient with a spinal cord injury in that last question. So again, if the patient's paraplegic, if the patient's quadriplegic, we don't really have an option there. We're doing a complete bed bath. Something that commonly comes up with hygiene, like I mentioned before, is dignity. Really, really big one with bathing. So again, patients quadriplegic, they can't help you at all. You're going to do complete bed bath, 1 to 2 people, if that. I'll still only uncover one body part at a time. Okay. In your bariatric patients, typically they have really deep skin folds, and you need to get in there deeply and clean as well. More importantly, after that, you're drying them off really good, drying in between the skin folds. But think about those patients and how you can make them comfortable while still cleaning and doing what you need to do. So take your time. Refresh your brain of other kind of the step-by-step of the skill if that were to come up. When you're bathing, you typically want to start distally and then wipe proximally. That helps with perfusion, lymphatic drainage, getting it back to the core. Okay, so distal to proximal. Yeah, good refresher on hygiene. Okay. Made it to our very first keyword for the quiz that you need to complete on Canvas to get credit for watching this video. I tried to use fun terms as the passwords or keywords. So your first keyword is dentures. Dentures, yay! D-E-N-T-U-R-E-S. Dentures. All right. Nutrition is our next topic, our next concept. So here's another practice question. A nurse is caring for a client who is at high risk for aspiration. Which action should the nurse take first? A, position the client in high Fowler's position during meals. B, encourage the client to drink liquids through a straw. C, mix medications in a cup of thin liquids. Or D, ask the client to speak after swallowing each bite. Say the answer in 3, 2, 1. The answer is A. It's another question using repositioning. That's pretty common. Good one with this topic, though, aspiration. Why don't we like aspiration? I'll let you answer that for yourself. But we want to prevent that in any way, any case. Okay, so do we like clients who are at high risk for aspiration to use a straw? No. It aerates the liquid. It also increases the speed in which it's coming into their mouth. Just asking for it, asking for the disaster. And C specifically mentions it being a thin liquid. When patients are at risk for aspiration, we're going to want to thicken their liquids to a certain extent. That would be ordered typically by a speech pathologist. Ask the client to speak after swallowing each bite. That's actually something that you could use to identify if they have aspirated, but it would be a late signal. It would send you a late signal that something is wrong. So then all of a sudden you stop feeding, maybe you can suction. Typically the damage is already done at that point. So again, we're going to aim for prevention. That would be our least invasive measure at this point. We want them to be able to feed themselves as much as they can too. Again, independence. So put them in high Fowlers, but stay with them at all times. Make sure their liquids are thickened. All right. Again, your most invasive option would be making them NPO or putting an NG or OG tube in, even more permanently, like a PEG tube. We want to avoid that if we can, though. We want them to be human and be able to eat their own foods. So do the little things that you need to do to help prevent aspiration. Okay. We talked about a lot of these already, but again, not going through your entire nutrition course, just thinking through these fundamentals topics. Aspiration precautions. So same like we just talked about, sitting up, taking small bites. Typically, you don't want to mix food and water or liquid. That can be a lot. Typically, they would want to have a special diet ordered. It can be like mechanical soft or pureed. Look for that if they have a history of aspiration or high aspiration risk. Okay, again, we talked about thickened liquids. There's a few different levels of thick, honey, nectar, fun stuff. And swallowing techniques, what does that look like when you want a patient to swallow carefully at risk for aspiration? Tucking the chin. Tucking the chin will help to close off the airway, okay? Now think hydration. Again, your least invasive options. If you know a patient is dehydrated or at risk for dehydration, encourage oral intake. Drink your water, drink your water. How much water have you drank? Track it, monitor it. It goes hand in hand with I&O calculations, right? But oral, aim for oral. If needed, of course, IV. We love that. It helps when we need it. Know the different types of IV fluids. That's going back to fluid and electrolytes, but you need to know it. Okay. And then the different types of diets, patient diets. So if you see that the patient has hypertension, maybe heart failure, cardiac issues, assume they're on a cardiac diet. What does that entail? Where's your brain? Low sodium. Pick a food item that has the lowest sodium. Avoid anything frozen, anything canned, typically. Aim for something fresh, nice and easy and fresh. Rice, fish combination, that's always a good healthy recommendation. a repeated low sodium. It could be assuming renal's on there too. Sorry to be so repetitive, but of course going through all the way down to NPO, soft, full liquids, clear liquids, know which one is which. And that we advance is tolerated after most procedures, after surgery especially. Going from NPO, clear liquids, clear that, full liquids, clear that, soft. Again, too regular or whatever alternative this patient has. Okay. Now let's jump into elimination. Here's another practice question. A nurse is developing a teaching plan for a client who has a new ileostomy and will require stoma care. Which of the following information should the nurse include? A, expect firm fecal content. B, avoid applying topical products to the stoma. C, clean the peristomal, my goodness, skin 2 times per day. Or D, empty the pouch when it is 1/3 full. Right. Answer in 3, 2, 1. D. Hopefully you got D. Did you remember that? We want to empty the pouch when it is somewhere between 1/3 and 1/2 full. Half would be the absolute max. So max. So we like to recommend 1/3 so that if it does get a little bit beyond that, that's okay. Now, the other options, looking at them, what's going to distinguish the answer A for you or not? That depends on the location of the ostomy. This is an ileostomy. So where is that coming from? Do you remember? An ileostomy coming from the small intestine, it's going to be pretty loose, pretty liquid stool, as opposed to a colostomy, especially if you specifically know that it's in the descending colon. That's going to be pretty formed stool. Okay. Now, C, clean the skin 2 times per day. You're only going to clean the skin when you are changing the entire system, which is typically every 5 to 10 days, many days in between those. Some facilities have shorter deadlines. I remember doing it every 3 days at Lakeland Regional years ago. But every 2 times a day, that's not realistic. Okay. So just tell them they'll be cleaning it when they change it all out every few days. And topical products are encouraged. They help to promote comfort and provide a barrier in between that skin. This is a new ileostomy again, so they're going to need some extra protection of that area so that it doesn't get worn out too quickly. All right, so again, D. Okay. Let's talk elimination. So we've got to talk both urinary and bowel. We got to start with bowel because we just went through an ostomy question. Constipation, we talked a little bit about earlier. Again, least invasive, start with water, fiber, ambulation, all the things that will help to get the GI system moving again. Enemas would be the next step up, actually. It's not taking a systemic medication like a stool softener or laxative. An enema can just help trigger that bowel movement, hopefully. There are a lot of different types, techniques to administer. That's thinking like position wise. They've got to be left lateral recumbent. Typically, we want left lateral. And we typically, depending on the type of enema, want them to retain it for a certain period of time. 30 to 60 minutes is common. So helping them back into like a supine position, if not high Fowler, something where they can use all their strength to hold this in their bowels as long as they can, and then help them on a bedpan to the bedside commode, whatever it may be, to hopefully have a bowel movement. If not, just get rid of the ostomy or the enema. My goodness, the enema solution. Bowel training programs, think incontinence. Okay, a lot that I could say about incontinence too, especially skin integrity. It's going to come up in a little bit. But bowel training programs help to give the patient a little bit more control on these bowel movements if they are incontinent. So think scheduled times per day for them to go. These are preventative things that we can try to do to help them avoid embarrassment and being uncomfortable sitting in their stool for long periods of time, right? Jump up to urinary, you'll see bladder training is there too as well, and continence management. Same idea, even if it's every hour on the hour, getting up and emptying your bladder. Whatever you got to do to train your bladder so that you have control and can gain strength back in that area if possible. Okay, but back up to Foley catheter care, insertion, removal. Do you remember the steps of that skill? Inserting, that's a sterile procedure. We talked about pericare, that's involved. You've got to clean the urethra and the area around it. Sterilely insert, inflate the balloon, make sure it's in place. Same with removal. Removal is not sterile though. Deflate the balloon, remove. By catheter care, how often do we do it? What do we need to do? What kinds of solutions do we use to clean the area? Look it back up if you don't remember. UTI prevention, oh, that can go right along with Foley catheters. That's really common, a CAUTI, catheter-associated UTI. But in general, if it's somebody that's high at risk, maybe they're overweight, maybe they have a chronic UTI condition, or they just don't have good hygiene practices, teaching them to prevent these. So again, wiping from front to back, especially for women, that's very common. Specimen collection, clean catch. That was a question on your capstone exam, if you remember seeing that a few weeks ago. But clean catch, you typically want to wipe the perineal area. You start the stream of urine. They'll start peeing, right? Lack of a better term. Then put the cup in the stream. So it's typically a midstream clean catch. You've wiped the area. It's not the initial urine coming out with any bacteria that might be on the surface. Midstream, okay? Versus sterile, that we typically want to get from either a straight catheter or from the catheter. If we're getting a specimen from a Foley catheter, do we get it from the bag or do we get it from the tubing? If you answered bag, shame on you. Now, we do not pull from the bag. Hopefully you remember that. There is a port up on the tubing. You'll kink the tubing, let it build up just a little bit, and use a syringe to pull from that port, okay? All right, that's elimination, which brings us to our second key word. Of course, it's feces. Feces, feces. Love it. Fundamentals. Next topic is ambulation and immobility. Okay, practice question based on this topic. A nurse is caring for a client who is on prolonged bed rest. Which device should the nurse use to help prevent the development of a deep vein thrombosis, a DVT? A, sequential compression devices, that's SCDs. B, incentive spirometer. C, pillows. Or D, heel protectors. Answer coming in 3, 2, 1. You don't need that long for this question. This is a pretty simple question. What helps to prevent a DVT? SCDs. Number A. Number A, letter A, choice A. Okay. TED hose and or SCDs, either one. That's what we need to help keep the legs pumping. Not going to spend that much time on this topic or this question. Incentive spirometer, helps to prevent atelectasis from immobility. Pillows and heel protectors are more for positioning and preventing pressure ulcers. These are all definitely effects of immobility, but specifically looking at a DVT, we need lower limb movement. If it's not ambulation, again, TED hose or SCDs. Okay. So let's talk devices. I don't really have time to go through every single device, every single pattern that you could use, especially when it comes to like crutches. Cane, I always remember from the acronym COLE, cane, opposite affected leg. You want the cane on your strong side, move the cane, then the weak leg, then the strong leg. Okay. Walkers, you want to pick up the walker, move it, step with your weaker leg, step with the stronger leg. Okay, crutches, all in all, for young people who have a good upper body strength, typically, again, different gait patterns, look that up. All in all, if you're going to use a device, the first thing you do is a safety check of the pathway. Okay, are there lines, devices, different things on the patient, on the walkway? Do they have their non-slip socks on? That's safety and infection control, if the question was just asking about that, but extremely important when it comes to ambulation, right? Wheelchair safety transfers, you know that there are locks on both sides of the wheelchair wheels. Um, Transferring does involve a good amount of, standing up all the way and then putting their hands back on the rails and lowering themselves down slowly. Takes some strength. So, what would you want to use to assist with using an ambulation device or to just transfer? What other piece of equipment? Gait belt. Do you think about a gait belt? Hopefully, so especially when it comes to transferring, lowering them down like that, hold the gait belt. Range of motion exercises. These can be active or passive. Again, if they are um, comatose, for an example, right? Or if they just don't have the strength, passive range of motion. Okay, help them to keep those joints loose. Active, if they can do it themselves, of course, they can do that pretty often, and you want to encourage that. Think about yourself, body mechanics and safe patient handling. Think about keeping a wide base, legs at least shoulder width apart, bend your knees a little bit. You don't ever really want to bend at the waist level. Waist is fine. Don't bend your back, hunching your back over. That's when you have back um, issues. Can't think of that word. Why am I losing that word? But a lot of the um, oh my goodness, I'm losing my brain at this point in time. The injuries that occur at work in the hospital, I wish I knew the exact percentage. More than 90% are back related, especially during patient transfers. Okay, so again, use those safe techniques that we know. And we talked especially in the practice question about adverse effects of immobility. So we know DVTs can occur. Prevention is key. SEDs, TEDOs, and again, movement, active or passive range of motion. Respiratory, that would be your atelectasis once again. So turn, cough, deep breathe, incentive spirometer. Muscle atrophy, that happens long term. Okay, so we need to ambulate them as soon as we possibly can and then as regularly as we possibly can. Contractures can also occur chronically, okay, where the muscles start to grow in on themselves and get shorter in a sense. Okay, we want to avoid those. So again, early, frequent mobility when possible, if not range of motion at the least. Okay. Skin integrity and wounds. Here's a practice question for you. A nurse is caring for an older adult client that is bedbound. Which of the following nursing actions is the priority in their care? A, assessing the client's vital signs every 8 hours. B, ensuring that the bedding is changed every 8 hours. C, repositioning the client in bed every 2 hours. Or D, completing the Braden scale every shift. Pause, think about it. Answer in 3, 2, 1. Answer C. Right? Hopefully you got C. We know Q2 turns. That's like drilled in our brains, right? We need to reposition at least every 2 hours. They're bedbound. Might even be more often in your facility, but look at the timeline on all the others. That was kind of a dead giveaway, if anything. Complete the Braden scale every shift, so every 12 hours. It's going to give you good information about how at risk they are, but we know they're at risk. They're bedbound. We know they're at risk. So, vitals every 8 hours and bedding changed every 8 hours. Important. We need the assessment data. We want to make them comfortable. Every 8 hours for a bed change is pretty often. Are they incontinent? Anyways, long story short, yes, repositioning. We're looking at their skin and how at risk they are for wounds. Okay. So again, we want early recognition and we want to prevent them. So again, changing position regularly, using pillows, heel protectors, any other device like that, to like a second line mentions pressure reducing devices. Bony prominences are the most common sites for pressure ulcers. So the heels, the sacrum, of course, the back of the head's a really common site too, the elbows, things that put pressure down on the bed that are bony prominences. Okay, look back through wound staging basics. Again, we're not diagnosing, but could we recognize a pressure ulcer that's a stage 1 as opposed to a stage 4? See all the way through the stage 4. Stage 1, just an area of non-blanchable redness. If you don't remember blanchable versus non-blanchable, look it back up. Okay. Basic dressing changes, it depends on what is ordered by the provider or the wound care team. That's really going to vary, but in general, know that like if a wound has tunneling, it's typically going to require packing. Wet to dry packing is the most common type then. It's really just going to vary based on what's ordered. Okay. Moisture management and continence care, we kind of talked about with elimination, but yes, urine especially, and loose stools, I should say too, highly acidic, very easily can break down the skin. So if it's checking them every so often and changing their bedding, wiping them off every time with a wipe or soap and water, some sort. Um, what do you think about using something like a barrier cream if you know that your patient is incontinent? Would that be helpful? Absolutely. I'll protect the skin. So if that's an option, let's do it. Again, as opposed to putting in a Foley catheter and leaving it in for the end of time if they're chronically incontinent. We don't want to do that. Puts them at risk for infection. It's also not very comfortable. Bag you got to carry around everywhere. So least invasive, we've just got to change you regularly. Okay? Change your position regularly. Change your bedding regularly. Okay. Next is our third keyword, and this is related to wounds. Didn't even bring it up, I forgot, but eschar and sloth. Typically what would be covering a stage 4, a stage 3 or 4 pressure ulcer if we're going to call it unstageable. It's unstageable if we can't see what's truly at the bottom because there's slough or eschar on the top. Slough is the yellow stringy tissue. It's non-viable, and so is eschar, black non-viable tissue that you can see in a wound. So long story short, your keyword is eschar, eschar. Okay. eschar, love it, wounds. Next topic is comfort, rest, and sleep. Practice question for you. A nurse is teaching a client who reports having trouble sleeping at night. Which of the following statements should the nurse make? A, take a 1-hour nap each day. B, stop exercising at least 1 hour before bedtime. C, watch television in your room before sleep. Or D, take a warm bath each night before bedtime. Think about it. Answer in 3, 2, 1. Answer is D. D. Hopefully you caught that. You might not be a bath person. We don't have baths in the dorm rooms. I hope not. That would be questionable. But that is just one example of an intervention that can relax somebody, relax their body, relax their mind. Okay, remember holistic care. We love that. Watching TV and being on your phone, what does that do? We know that that impacts the way that we sleep. The light, the blue light that's in our phone, especially, it messes with our hormones and it helps to keep us awake. So, not recommended. Sorry, be the bearer of bad news. Again, I know you've heard this before. Stop exercising at least 1 hour before bedtime. It's actually 2 to 3 hours before bedtime. That, especially depending on your age, diagnoses, etc., it can take that much time for your body to truly relax and go to sleep. Okay, and naps. Oh, we love a good nap. We love a good nap. But we want to avoid naps, especially if we're having trouble sleeping at night. Naps are going to kind of hurt the process, right? Um, you learn that when you have kids. I've been through that with Henry. If they stop sleeping well at night, their naps are too long during the day, they have too many naps during the day. But same with adults. Again, elderly people are basically just big babies. I don't say that offensively, but it's true. Um, so avoid naps. In general, we want to avoid naps. What is going to help a patient sleep that's having trouble sleeping? Taking a warm bath, doing something to relax at nighttime. Okay. Very commonly asked about comfort, rest, and sleep. Now, comfort, that's a whole nother thing. Pain, again, least invasive, least invasive. So if you have a non-pharmacological intervention listed in your answer choices, give it a try. It's probably that. Repositioning, especially think surgery, surgical incisions. Okay, reposition them in a way that there's no pressure on that incision. You very likely might need pain medication with something like a surgery, but again, that's a starting point. That might be able to delay the medication just a little bit. Same with using like heat and cold therapy, massage, acupuncture, acupressure. We're going to talk about those things a little more in the next section, which is complementary therapies. So pause on these interventions, but start there if the patient's complaining of pain or feeling uncomfortable. Okay. Especially if it's mild pain, 0 to 3. Now, sleep hygiene, we talked about some examples with that practice question. What disrupts sleep? Could be lights, could be sounds. It could be something as simple as giving a patient that has a roommate or something like that an eye mask or earplugs, turning off unneeded lights, making sure their remotes are right next to them so they can turn the TV off. Um, Other things impact the way that we sleep too, of course, like caffeine. Nicotine and alcohol do as well. Okay, avoid those several hours before bedtime. Exercise is good and it helps to tire out our body in a way. But again, you want that to be several hours before bedtime. A bedtime routine is a really common way to help your body to relax on time on that daily schedule. So having something established, take a warm shower, get in your pajamas, lay in bed, read a book, productive things, and then go to sleep. In the hospital, clustering care is something that's going to come up a lot too. Of course, we know we try to lump together as much as we can to interrupt the patient as little as possible. We do it when we can. Hopefully we can often. All right, but again, leading us right into this next category, complementary therapies. This practice question is a little bit of a different angle to it, but we'll talk about it. Here's practice question. A nurse is caring for a client whose morning laboratory results show a serum potassium level of 3.3 MEQs. What is that level? What's the normal? Which of the following statements should the nurse include when educating the client about this result? A, ask your provider about receiving potassium injections to raise your potassium level. B, including potassium-rich foods such as bananas in your diet can help you raise your potassium level. C, you should take a prescribed oral potassium supplement with food to help restore your potassium level. Or D, you should avoid eating fruits high in potassium until your next laboratory test. Answer in 3, 2, 1. What's the answer? B. Hopefully you got B. Okay. Again, look at the level. 3.3. Is that high? Is that low? Is that normal? It's a little bit low, but just a little bit. Okay. Are we to the point where we're really concerned something is going to happen to their heart or muscles, any other organ? Not exactly. It's not considered critical. So it would be appropriate to recommend oral replacement of potassium. Now, again, what is an oral supplement? It's a medication in a hospital. It has to be ordered. It's over the counter, at drugstores, but it's an order in the hospital. So you as a nurse, even before you see the doctor rounding that day, if they do even round, that's something that you can say, hey, with your breakfast today, get a banana. Get a banana. Let's eat a banana with every meal today and hope that that can give you a little bit of a boost in your potassium. Of course, mention it to the provider. Tell them you encouraged oral intake. They might even still order the oral potassium, but that would be the next step, right? So diet, then oral supplementation, then an injection, whether it be a shot some sort, or IV infusion, especially with something like potassium. That's something we take really, really carefully. We don't love giving that IV, but if we have to, we have to. If it's critical, typically. Okay. And then, of course, D is just a throwaway. Why would you avoid eating fruits high in potassium? That's if you were confused and thought that might have been high. Review those levels, though. They're typically going to give you a range on the NCLEX, but if they didn't, if it was a situation like this, okay. So complementary therapies, again, we mentioned a few of these when we talked about comfort just a few seconds ago. They're all going to be recommended based on what the complaint is from the patient. That's going to vary. And I don't think anybody really expects you to be an expert on all of these and what would we use for which conditions. But again, know that they exist. Know that they can be recommended in certain situations and encourage it. Okay. Also make sure that they're safe. Okay. Something like acupressure, acupuncture, herbal supplements. That's something that you would have talked about a lot in pharm and in psych. Things like St. John's wort can help in certain instances, can interfere with a lot of meds as well. Okay. So safety check, but also respect their wishes. Okay. Um, Cultural sensitivity, that goes in hand with it because there are a lot of patients, ones that you're going to encounter, that have different cultural beliefs and practices. And again, unless it's something that is life-threatening for them, you're never going to tell them no. You've got to respect it and find a way to work around it, whatever it may be. Certain cultures and ethnicities have what they call hot and cold illnesses. So say that they have something going on, they'll only eat hot foods. Okay, that might interfere if you need to give them a liquid medication that's stored, at room temperature, perceived as a little cool. Just an example, find a way to work around it. We're going to respect it though, right? Okay. Another thing to think about, same idea with what we talked about in the practice question. If a client has low iron, what would your first suggestion be to increase their iron? Now you're thinking back to your nutrition course. What's the very first thing that we do? Somebody has low iron. We need to identify the cause and try to fix it. If it's iron, can more than likely going to be associated with bleeding. Could just be an all-around deficiency, but they could be pregnant. If it's something like they're bleeding, especially think like GI bleeding, let's find it. Let's try to get it fixed. Increase your iron levels from there. Okay, but identify the cause and fix. That's always going to be first step in the process. Then again, like we talked about diet, what has high iron? Red meat, spinach, lentils, cereals. Then if we're still deficient, oral supplement would be next. Like we talked about, vitamin C enhances iron absorption. Fun fact, if you didn't remember that, there's a lot that go hand in hand like that. So look back through those. But all in all, oral supplements not doing it. What else can we do? An IV infusion, of course. Remember that step-by-step process. That's your least invasive framework right there. Okay. Next is therapeutic communication. Not going to go too in depth on this one. This is incorporated in everything that we do. But practice question, a nurse is teaching an older adult client who has significant hearing loss about a new medication regimen. Which action by the nurse demonstrates effective therapeutic communication for this client? A, sit facing the client, speak clearly, and use simple written materials during the teaching. B, speak loudly while standing on the client's impaired hearing side. C, provide detailed verbal instructions and ask the client to repeat them word for word. D, turn down the lights so the client can focus on the nurse's instructions without distraction. Answer in 3, 2, 1. Definitely A. And I hope you answered that in the same way. Definitely A. Turning down the lights so that they get focused. Oh my gosh, that's just insensitive. But it would also interfere with their ability to lip read. If they are lip readers, they have significant hearing loss, probably been around for a while. Don't do anything to interfere with that. verbal instructions and make them repeat it word by word, that's not effective. There are definitely other things that you can do. I mean, if you're in the middle of nowhere, you don't have any resources to use, you might need to do that one day. But no, if step number one is sitting, facing the client, speaking clearly, and giving them written materials, anything with a written material with hearing loss is a given. That is just given. Unless, of course, they have both vision and hearing loss. You never know. And then you're going to want to look for a family member or a proxy of some sort to help give instructions to as well. All right, but we know speaking loudly doesn't do anything. It actually increases the pitch of your voice, typically makes you talk a little faster too. Not helpful. Okay, so basics in therapeutic communication. These are basic techniques to use: active listening, empathy, reflection, clarification. We love open-ended questions. Same idea with clarification too. That would be asking a question back to them. Like, I don't know, do you think I should have this procedure? What's worrying you about the procedure? Or tell me what you know about this procedure. Tell me what concerns you about this procedure. Okay, get more information. Don't give your opinion. Your opinion does not typically matter. I'll say that in a mean way, it's the patient and their wishes. That's all that matters. Okay, but in regards to education, we just talked about hearing vision deficiencies, use whatever methods they require or they desire. Same with language barriers. Can you get by signing everything that you're doing? Gonna get blood, IV in. Now call an interpreter, okay, translator, interpreter. Use written materials that are in their language, whatever it may be. Very common one to come up is asking about, can a family member interpret for them? Remember that they can't if it's anything that is diagnosis related, anything directly related to medical care. Now, if it's, did you order lunch today? The family member can ask them that, of course. Do you want to take a shower today? They could translate in the moment. But always, that's going to be your safer option, translator. All right, our last content area, thanks for bearing with me, is end of life care. Okay, practice question here. A nurse is assessing an older adult client who is receiving end of life care. Which of the following assessment findings indicate that the client is near death? A, clear breath sounds. B, regular breathing pattern. C, Shane Stokes respirations. Or D, Kussmaul's respirations. 3, 2, 1. Our last question. The answer is C. Hopefully you remembered that. Hopefully you've watched Professor Cipriano's video on diabetic emergencies. She would have talked about that with DKA, that Kussmaul's a common anything metabolic acidosis related. Shane Stokes, you'll hear it called Kind Stokes, Shane Stokes, all kinds of things. But those are typical end of life sign symptoms. So is modeling, a lot of other telltale signs at end of life. Breathing pattern is not regular, though. That's what Shane Stokes is, very irregular. Periods of apnea followed by periods of hyperventilation. That's Shane Stokes. And sounds are typically not clear. They get what they call affectionately the death rattle. You can audibly hear the death rattle. They have wet sounding lungs. Not reassuring to the family, but again, it is a physiological part of end of life. Okay. So non-pharmacologic, always we want to start there, make sure they're positioned comfortably in bed, still follow Q2 turns, keep them comfortable. Positioning for dyspnea, so that's stupid. They can sit up. You can put them in high fallers if that will help. They can also be prone if that will help. Again, you can give medications to make them comfortable, all in all. Oral care still routinely every few hours if they have no oral intake. Culturally sensitive comfort support, of course. And post-mortem care, I want to spend time talking about, though. Time of death is called. Okay. We need to know if they're doing an autopsy or not. Do we need a medical examiner report or not? If they do, then you cannot remove any lines or devices. Okay, leave any IVs, catheters, anything in place. They will have to remove them. It's part of their process. That's okay. If not, no autopsy, no anything. We're just going to take the body right to the funeral home, remove the IV, remove any devices, wipe the body off, full-on bed bath if needed, if desired. Place a waterproof pad underneath them because they will start to release fluids, typically a little bit of urine, a little bit of feces. Okay, anything can come out at that point in time. But clean the body if their eyes are open, close their eyelids, make sure they're in a comfortable position, hands together on their abdomen, whatever it may be. Make sure family can be with them and sees them. Very, very delicate time, lots of therapeutic communication going hand in hand there. But that's a common one that you can be asked about. Okay. All right. Hopefully I didn't do too terrible on time. Thank you for bearing with me. Like it says right there, you can do it. If you have any questions about anything that I went through, my email's there. I'm on your Canvas page too. Inbox me, get me somehow. I tried to be kind of vague to A, not take a ton of time, but also B, help you identify areas that you need to review. So look back through ATI. At this point in time, AI is going to be a big friend of yours. Use a prompt like, I'm a nursing student studying for the NCLEX. What do I need to know about postmortem care? Insert blank there. But let me know. Good luck, you guys. Y'all are awesome. Keep doing what you're doing. Take care.